Thank you, Dr. Shannon, and good morning. I'm very pleased to have an opportunity to highlight quickly the work of two colleagues in the profession of optometry, Dr. Carol Timpone and Dr. Jennifer Smythe. Dr. Timpone is Distinguished Professor at Pacific University and also Interim Associate Dean for the clinical program there. And Dr. Jennifer Smythe is the Dean of the College of Optometry at Pacific University and also the current president of the Association of Schools and Colleges of Optometry. I've had the opportunity to represent ASCO at the Global Health Forum. We are a relatively new member of the group. We've been so impressed with the work and dialogue of the forum, and we're delighted to be here. And I'm particularly pleased to present this project to you because it illustrates how doctors of optometry are the primary eye and vision care providers, meaning that we take care of the majority of eye and vision care needs for the majority of patients the majority of the time, and we are a key member of the healthcare team. In order to address the needs of the members of the growing predominantly Latino population in Western Oregon who have diabetes, and to prepare students for community-based collaborative healthcare delivery models, the Pacific University College of Optometry and its College of Health Professions have developed and implemented an innovative model for interprofessional education and culturally sensitive collaborative care. This model is the Interprofessional Diabetes Clinic, or IDC. The IDC at Pacific University in Oregon employs a teaching and patient-centered model that provides optometry, dental health, physical and occupational therapy, mental health, physician assistant, and pharmacy services. Patients are evaluated by faculty and students from up to 3 of those disciplines in one evaluative visit in order to improve access and to promote collaborative coordinated care. The patient evaluations conclude with a team-based management conference that is led by student facilitators and presenters, and that team-based conference is also facilitated by the use of integrated electronic health record systems. A very key member of this team at the IDC is the bicultural patient care coordinator. This individual provides patient navigation, coordinating services, follow-up care, and along with other community trainers, the patient coordinator provides patient education in diabetes and chronic care using the Stanford University Chronic Disease Self-Management Program. Patients access the IDC and become familiar with its availability through community health centers, outreach efforts, and information that they receive at other university-based clinical facilities. This slide illustrates the patient demographic data and some healthcare statistics from the past 2 years of implementation of the IDC. And I hope you would agree that the data really reinforce the need for intervention and for interprofessional care. 63% of the patients that are summarized in this table were female, 37% of course male, 90% of the patients are Latino. So you can see in line 1 of the table that the mean age of the patients seen at the IDC was 50 years. Also, please note that using the body mass index criterion, the majority of the patients are considered to be overweight. The hemoglobin A1C data clearly indicates either undiagnosed diabetes or uncontrolled diabetes for a long period of time. You can see that the systolic and diastolic blood pressure measurements were quite reasonable looking at the mean data, but noting that there were some outliers there with the systolic ranging up to 191 and the diastolic measurement up to 107. In looking at the first consecutive patients who were evaluated at the IDC, 42% of the patients exhibited diabetic retinopathy. As you know, that is vision threatening and of great concern. More than 10% of the patients presented with glaucoma, and 100% of the patients were evaluated to have periodontal disease. A third of the first 50 patients seen required physical or occupational therapy intervention, or would benefit from behavioral intervention to mitigate barriers to self-management. To assess the success and impact of the program, patient satisfaction and student satisfaction data were collected. Looking toward the bottom of the slide, you can see that overall the patients were very satisfied with the care and services that they received, 97% of the patients indicating that they would refer others to the IDC. The students also rated the program very highly, and this obviously was across student disciplines. Overall, they rated the experience 4.5 on a 5-point scale, with 5 being excellent. They also rated quantitatively the knowledge and respect for all the participating professions that they received. They rated that at the level of 4.6. They rated the collaborative learning environment that they experienced at the level of 4.2. And they rated their more comprehensive knowledge of diabetic patient needs as 4.5. Again, those data also all on a 5-point scale, with 5 being excellent. This final slide highlights some of the conclusions, certainly some of the advantages of the interprofessional diabetes clinic. The IDC has provided the opportunity for students to gain firsthand team-based, collaborative, multifaceted, community-based practice experiences that focus on the whole patient. As you well know, diabetes is a multi-system chronic disease and certainly is a natural starting point and an important component of interprofessional care and interprofessional clinical teaching. Integral to the success of this patient-centered model, as I mentioned previously, is the patient care coordinator, who employs a culturally sensitive and competent approach in partnering with patients in the community. And this individual assists in the effective coordination of care and patient self-management education. As shown on the slide, the advantages of this community-based model are many. Several are summarized here. First of all, obtaining a more comprehensive rather than a disjointed patient history has been a great advantage, especially when the history is gathered within the different contexts of each profession, which aids in the development of a more comprehensive evaluation and treatment plan. Second advantage, enhanced opportunities for both patients and providers to identify and address key barriers to successful self-management, and certainly the delivery of consistent coordinated patient education, as we said. Some challenges as the IDC partners with the community certainly have been language and cultural barriers, which are on the way to being addressed. Developing and implementing an integrated electronic health record has been a challenge. And certainly a challenge, but yet a wonderful opportunity, is for the multiple disciplines to understand each other's roles, practices, and to experience them firsthand. So in conclusion, the Pacific University Interprofessional Diabetes Clinic is a viable community-based model for providing patients and students the benefits and experience of comprehensive and coordinated collaborative patient care. Future goals for the IDC include expanding services to diagnose and manage other chronic conditions and to developing more robust evaluation measures of student education and patient care outcomes. Thank you again.
Thank you very much. Our next speaker is Rob Russell of the Academic Consortium for Complementary and Alternative Healthcare.